first of all, some more images there. This is a T2 weighted MRI, this is a T1 weighted. Now, where we exactly look for in such a case, focus on this axial picture. What you see here, the 7th 8th nerve complex on the right side. You see? And what you see here, the 7th 8th nerve complex on the left side. This is the intra-auditory meatus, leading laterally. Anteriorly, this is cochlea, and posteriorly, this is semicircular canal. The organ of hearing and the organ of balance. This contains 4 nerves, 2 vestibular nerves, 1 facial and 1 cochlear nerve. The cochlear nerve go anteriorly, vestibular nerves go behind to supply the vestibular structure, and the facial nerve go further anteriorly in the facial canal. Now see where the lesion is exactly. Cerebellopontine angle on this side, where this intra-auditory canal is emerging from. This is the pons and this is the cerebellum. That's the angle. At the same point in the opposite side, you see the lesion at the CP angle. Now, once you find a lesion in the CP angle, there could be variety of situations. Most common lesion we'll know is a vestibular schwannoma, or what we call it more commonly as a acoustic neuroma. Now, how can we differentiate? There could be meningioma, there could be a epidermoid, there could be variety of lesions like this. The typical vestibular schwannoma has a canalicular extension. From the canaliculus, it bulges in the cerebellopontine angle. See this? This is the canalicular extension. And see, very important part in decision making. In acoustic neuroma, the decision making, that how it can be removed best, is a very, very complex process. There are 3 common approaches: middle fossa approach, retrosigmoid and translap. And there is always a sort of confusion or a sort of matter of discussion that what approach should be best for every lesion. This is a very complex decision making process, and one of the important factors, decision making factor, is the extension into the intra-auditory meatus. See here, the tumor is extending far laterally in the intra-acoustic meatus. Just a minute. Now, as I was saying, the differential diagnosis between the meningioma, epidermoid and the acoustic schwannoma is important for the management planning. Since it involves a rise in the intra-auditory meatus, the symptomatological presentation is because of compression of either of these nerves. More commonly, it arises from the vestibular nerve, more commonly inferior vestibular nerve. In the intra-auditory meatus, there are 4 nerves, and they are oriented in a fashion like if you see from behind. Antero-superiorly is facial nerve, antero-inferiorly is cochlear nerve. Okay? And posteriorly both superior and inferior vestibular nerve. It arises most often, if you go to the literature, 85% or more, it arises from the inferior vestibular nerve, which is closest to the cochlear nerve. So mostly they present with the auditory symptoms. As it compresses the cochlear nerve, mostly it compresses the auditory nerve and present with the auditory symptom, maybe tinnitus, maybe hearing loss, maybe gradually progressing, maybe all of a sudden hearing loss, whatever. And a tumor arising from the inferior vestibular nerve is a negative component as far as the hearing preservation is concerned, because it has already compressed the cochlear nerve. So, in differential diagnosis, this component which is extending in the intra-auditory meatus itself is suggestive of a vestibular schwannoma. Now, why it can't be meningioma?
Tail anteriorly, tail lateral.
Yes. Your point is good, that meningioma has a broad base attachment on the meninges. So we'll show on enhancement, on a contrast enhancement, we'll show a dural tail of the meningeal enhancement, which is not there. Secondly, meningioma will not show the canalicular extension so commonly, intra-auditory meatus. Thirdly, meningioma in contrast will enhance differently. It may have a calcified component, or it may enhance variably. The acoustic schwannoma, again it may enhance variably because of the necrotic component in between. But see here the lesion right at the CP angle going in the intra-aortic meatus with no dural tail. Self is suggestive vestibular schwannoma. This patient presented with a auditory symptoms. He has a profound sensory neural hearing loss. Okay. And why this is important to diagnose this differential diagnosis? Because choosing the approach. Had this been a meningioma, suppose at the CP angle, I would not go trans-lap in that situation. I would do everything to preserve the hearing. Why unnecessarily sacrifice the hearing? Meningioma do not invade the canal and do not give so frequently the hearing loss, unless they are so big and compressed the nerve at the CP angle. So then your retrosigmoid approach is straightforward and you can preserve the hearing. Now here the hearing preservation is I would say a Herculean task. It's an unimaginable task which is unnecessarily an issue of controversy. It is not an issue of controversy for that matter. If you go to Mario Sana's concept, the guy who has done more than 3,000 acoustic. If the tumor is going in the intra-aortic meatus, forget about that much in the intra-aortic meatus, forget about hearing preservation. Which is intra-acoustic meatus is a bony structure, is a bony canal, incompressible bony canal. Tumor which is expanding in the intra-aortic meatus, what will it do? It will compress the nerve, and the most sensitive one is the cochlear one. Once it compresses the cochlear nerve and gives hearing loss, that is irreversible. So the component which is going far laterally, see here far laterally in the lateral part of the intra-aortic meatus, forget about the thought of hearing preservation. It cannot be. Simply it cannot be. So these are the important things to be seen on MRI. Though we don't have a MRI where I usually get the MRI done for my person, which give me the required details. This patient brought the MRI done somewhere else, so I didn't find it to get it done again because the diagnosis was straightforward. Now what else? Like Murali you were saying, the relationship to the vein, the vessels. You said the ICA may be related. Yes, all these are related, but how they are within the arachnoid plane. Whatever neurovascular structure here is, see this? Can you see this black shadow around it? What is that? That's the arachnoid plane, the CSF. So if you, when you do remove the tumor, stay within the tumor, do intratumoral debulking, separate in the arachnoid plane, and all important structures are automatically away unless you breach the arachnoid and go and injure that. So that is another issue. Now, when it comes to decision making between choosing, as far as choosing approach is concerned, whether a middle fossa, retrosigmoid, or a translap, I give you a very simple explanation, which what we believe and what we learn from Mario Sana's expertise. Retrosigmoid is a fastest approach. It's amazing neurosurgical approach. Here the people who are proponent of the retrosigmoid, I have two questions. One is, it's not about the fastest approach. One is to remove the intracanalicular component, and second is the imagination of hearing preservation. Believe me, any tumor which grows more than 2.5 centimeter, practically, 2.5 I am talking too much, even 1.5, preservation of hearing is in the dreams, practically. Hearing means the serviceable hearing. You get a pure tone audiogram, you may find a 30-40 dB hearing loss and assume that you still can preserve the rest of the hearing. You get the speech discrimination score, that is more important parameter of hearing preservation, and you will find very, very poor. To me, a patient with a 40 dB pure tone loss with a very low speech discrimination score doesn't mean any hearing. Practically, it doesn't have any serviceable hearing. So, when we talk of hearing parameters, it should be the speech discrimination score, which should be considered as a parameter for hearing preservation. In tumor, any tumor above 1.5 centimeter, the SDS is almost always low, and whatever hearing you preserve is not serviceable. Now, another thing about the intracanalicular component, the tumor which is ascending far laterally in the canal, practically it is not possible to remove by the retrosigmoid approach without sacrificing the hearing organs. You know what happens? The proponent of the retrosigmoid, what they propose is for the canalicular component, they can drill the canal from behind, part of the canal, and then they use the telescope to pluck up the lesion, whatever going laterally. But a tumor which has ascended far laterally in the canal, first of all, has already compromised the hearing. Even if you remove it completely, the hearing is going to go. Secondly, when you drill the canal, you have to be very, very careful not to injure the posterior canal or the endolymphatic sac and compromise the hearing. Having done the retrosigmoid and compromised the hearing, then what is the fun in choosing that approach? And then indirect removal through the telescope or mirror, whatever, cannot give you a certainty of complete removal of the tumor. So, our approach for any lesion which has a deep canalicular extension or more than a 1.5 or now we can say 2 centimeter, the straightforward is the translabyrinthine approach which we are going to do. The advantages are numerous. Obviously the advantage of retrosigmoid is a fastest straightforward approach where you can reach the tumor within 20 minutes. Yes? You don't have to drill the temporal bone at all. Here the biggest advantage is the facial nerve and the post-operative problems which can be minimized by this approach rather than the retrosigmoid. The post-operative problem of CSF leak and re-exploration, all these are favorable with the translabyrinthine approach. Now here, in the translabyrinthine, once you go from anteriorly, the first thing you see is the intra-aortic meatus. In the intra-aortic meatus, as far as the nerves are concerned, the first nerve you see is the facial nerve, immediately anterior to femur tooth. So the first critical structure you identify in the translab approach is the facial nerve. That gives you the best opportunity to preserve the facial nerve. In the retrosigmoid, when you come from behind, that nerve is anterior to the tumor. Between the nerve and the surgeon is the tumor. You don't see the nerve directly in the beginning, and the preservation is very, very difficult. Here, the nerve preservation has a best opportunity in the translabyrinthine approach. So I will show you the entire anatomy of the translabyrinthine approach. Second caveat proposed by the retrosigmoid group is the exposure. Obviously, the retrosigmoid gives the widest exposure of the posterior canal fossa, the most versatile approach to deal with any lesion in the posterior canal fossa. Now, the issue is with the translabyrinthine approach, you can remove any big size tumor. May not be, the window may not be so big, but after the intratumoral debulking and mobilization of the tumor, you can remove up to 5 centimeter tumor with the same ease. Here. So I'll show you how you can mobilize a big size tumor through that window in the translabyrinthine approach. So size of the tumor has no criteria to choose between the retrosigmoid and a translabyrinthine approach. Size is no criteria at all. Criteria is facial nerve preservation and the complete tumor removal from the intra-aortic meatus. These are the two biggest factors which should be taken into consideration. A few words about the middle fossa approach. It's again a very good approach. The obvious reason to talk about the middle fossa is to preserve the hearing. So for any intracanalicular tumor, why this approach was proposed initially? For intracanalicular tumor, limited intracanalicular tumor, to preserve the hearing, the best is the middle fossa approach. Very good. But if you analyze, I tell you the pros and cons of that approach. For any tumor which is within the intra-aortic meatus, this is the lateral end, this is the medial end. Any tumor occupying the intra-aortic meatus completely can be removed with the middle fossa approach. The problem is, any tumor which is completely occupying the intra-aortic meatus, the hearing is already. It's very unlikely to see a good hearing with a tumor completely occupying the intra-aortic meatus. For a lateralized lesion in the intra-aortic meatus, yes, the middle fossa is still a good approach or a good option, because You can preserve the hearing, but the only thing is when you come for the middle fossa approach from above, you have to go to a tumor which is arising from the inferior vestibular nerve. You have to go across the facial nerve. You have to literally mobilize the facial nerve, which is detrimental to the facial nerve function. So in middle fossa, when you think of such lateral tumor in the intra-aortic meatus, preserving the hearing, you have to tell the patient that could be at the expense of facial nerve paresis, maybe palsy. The paresis is imminent when you manipulate the facial nerve in the intra-aortic meatus or the middle fossa approach. Secondly, for tumor which is medially placed in the intra-aortic meatus with a good hearing, I would vote for the retrosigmoid approach, because those medially placed tumor in the intra-aortic meatus can be removed with the retrosigmoid approach with better preservation of hearing without manipulation of the facial nerve. So for medially placed tumor, isolated tumor of the intra-aortic meatus, to me the best is retrosigmoid. For laterally placed middle fossa, for complete canalicular involvement with practically good hearing, still you can go with the middle fossa, but that is unlikely, and then ultimately the translab is the approach. So bottom line is, anywhere the hearing is gone, SDS, speech discrimination is scored. The approach of choice for any size tumor is translab. For small tumors with good hearing, limited to the canal, particularly laterally middle fossa. For small tumors medially placed in the canal or CP angle with good hearing, this is the gross differentiation how to choose the approach.
What about endoscopic, direct endoscopic transcochlear removal of vestibular?
See, this has been approach recently introduced. I went through the pre-settled article. So they are developing the transpromontorial approach to the intra-aortic.
But unnecessarily cochlea is damaged.
Yes. So once the hearing is going,
waste.
What is the fun in going with the endoscope? Yes. Why don't you take the best exposure with the translab?
Yes.
So that is the approach which is being developed or in the developing stage, proposed by people.
But cochlea is unnecessary sacrifice.
But they have to find the indications yet, and that is not the standard of care.
Okay, another last question, sir. When neurosurgeon is going by retrosigmoid approach, when the tumor is a little bit lateral in the internal aortic canal, when he is drilling, there are chances of sacrificing the posterior semicircular canal ampulla.
I mentioned.
Okay, you mentioned. Anyhow, in translabyrinth, then also you are damaging.
Yes.
They will also damage what is this?
The retrosigmoid approach proposed for the tumor which is extending laterally in the intra-aortic meatus is of no use.
The same thing we are also doing.
Laterally in the intra-aortic meatus, why do you go by the translab? Once you are sacrificing the hearing, then there cannot be any better approach than translab. The only disadvantage of the translab is definite sacrifice of hearing. Once the hearing is going to be sacrificed or already gone, there is no question about choosing the approach.
What neurosurgeon argument is, we are doing very fast, direct approach.
Agreed. Retrosigmoid is the fastest axis. Agreed. But I told you so many factors you need to take into account for choosing approach. It's not about the time, the fast approach. You go fast and leave the tumor behind, then what is the fun? That's not the science. Another problem is, that's why it's a teamwork between the neurosurgeon and the ENT surgeon. It's like in cancer we constitute a tumor board. Similarly, there should be a board within the ENT and neurosurgeon to decide an approach, that what should be the best for the patient. It is not the surgeon-driven approach. It should be the patient factor-driven approach.
What about role of endoscopic retrosigmoid approach by paracerebellar axis? Cerebellar axis.
For what?
At the superior border. Suppose if the tumor extends to the prebasilar area, they can keep an endoscope and they remove by retrosigmoid.
Translab is versatile. Wherever it is going. If it is going far anteriorly,